I'm Tilly Collins, and along with Polina Levontin and Adrian Leach, we are the Imperial College section of Get Campy. And we are the people who are working on the Bayesian belief network modelling that fits within the Get Campy project. So the project seeks to quantify infection sources and make the genetic and the socio-economic data that it collects useful for public health policy. This can then help design or reinforce the interventions to reduce diarrheal disease. Now, data by itself can't inform policy. It needs to be interpreted. And BBN is one of the methodologies that can be used to create or explore connections between various sources of evidence and specific policy options. Of course, no policy or intervention can be effective if it does not account for local culture, social norms, economic realities and so forth. And BBNs can bridge domains of localised knowledge and your genetic analyses. So Campy will answer questions such as, how likely is a chicken a source of Campylobacter infection, depending on some socio-economic or cultural factors. And this quantification of specific transmission networks will also inform pathways of relevant pathogens more generally. So information collected in this project can be synthesised by experts with their existing beliefs about the transmission of disease and the intervention options, and BBNs are exactly the tool to perform such a synthesis and to document it in a formal way. We know there are many serious infrastructure and cultural issues affecting Campylobacter infection in the population. And by understanding the risk factors for infections, interventions, both physical and educational, can improve population health. For example, by comparing different rural to urban cohorts, we'll be able to assess the impact of living quality and sanitation on infection. And we will also be able to compare different population, food, water sources, age groups, comorbidities, etc. Bayesian belief networks help by bringing this existing knowledge together with the insights from the project's data. And we can begin to understand the relative importance of factors, such as household crowding, poor sanitation, contaminated water, or living with animals. BBNs can represent lots of different systems in a way similar to concept maps or influence diagrams, which are often steps in the building of the network. The analysis of data can be summarised and communicated to public health officials, and enabling better informed decision makers likely to make more effective policies. Of course, this is also subject to constraints such as funding or local politics, as successful implementation depends on a range of social, technical, cultural and economic factors that can also be explored in the BBN. The project can also contribute to improved disease monitoring. And monitoring is crucial in managing outbreaks and in assessing the effectiveness of interventions over time. Finally, improving understanding of transmission networks can help direct interventions in a more targeted way. For example, education resources can be prepared to communicate the greatest causes of risks and how people can reduce their exposure or vulnerability. This here is a concept map bringing these arguments together. A resulting model is important, but the revelations and reconciliations and consolidations of different beliefs and conflicting narratives that happen in the process of building the model can bring stakeholders together, enabling consensus where none seemed possible at the outset. So, what are BBNs, who uses them, and how are we going to build them? Well, they come in different shapes and sizes, and here is a very simple example. All the bits are connected, and the direction of causality is known. Here we show that access to care can improve child health. However, in reality, the reverse can also be true. Care is a limited resource, so if fewer people need it, then access may be improved to those who do. Positive and negative feedback loops might exist and might be important, but they are difficult or impossible to capture with a BBN this simple. Although we specify directions from parent to child variables, the key feature of a BBN is that information flows in both directions and throughout the network. The structure of a model can also be learned from data, but this is only a viable option when there is a lot of high-quality data that is available. Increasingly this is the case, especially in medicine where BBNs are widely used. And here is a model of diagnosing liver disease that is built both with medical expertise and lots of data. Those aimed at human users are a lot simpler and involve fewer parameters and explainable structures. The models we aim to build will be similar in size to the decision support model here. Here is a BBN that was built to explore policy options for managing a fishery and was part of Polina's PhD. This evaluated choices of both objectives and management decisions, represented by the rectangles, in the light of the preferences of different stakeholders. This is why there is a link from objectives to commitment, because some stakeholders made it clear that they will not commit to a decision if they disagree with management objectives. Basically, they were open about not complying with regulations if the framework was not designed with social objectives in mind that took their values into account. Therefore, there is this intermediary variable called implementation that depends both on what the decisions have been taken and on the commitment of the stakeholders to the decision. This context is similar to ours. There are interventions to consider, such as community education campaigns, subsidised domestic water treatment, or other improvement to living conditions. There are cultural, social and economic factors that influence the success of these interventions. There are also budgetary constraints as to how quickly decisions, such as piped water or improved nutrition education, can be implemented. These are part of our network. Here you can see the utilities or diamond-shaped variables that represent the beliefs for different stakeholders. 3 utility functions represent the 3 groups of stakeholders: those interested in catching and selling fish, those interested in catching fish as part of recreation, and those interested in fish just being there in the rivers as part of a healthy biological ecosystem. The intermediary variables of this model capture how salmon stocks respond to different management regimes and are summaries of a complex bioeconomic model that had been built alongside the BBN. In a way, the network summarises different sources of knowledge, model-based results, expert opinions, insight from people working closely with the stakeholders to understand their preferences. Similarly, our BBN for Get Campy will combine insights from the genetic study, the socio-economic data collected by the project, a literature review, and the knowledge of local experts. We do have plenty of evidence that eradicating poverty, improving education and nutrition, and providing clean water and sanitation reduce diarrheal disease to very low levels. We also know that we need to deliver all of these and not choose between clean water or education, for example. So it's not a BBN that is the missing element needed to convince a decision maker to act. The missing element is essentially funding. So the question then becomes this: given very limited financial resources, how should these be allocated to reduce diarrhoea in children? This is where the BBN can be helpful. BBN can synthesise all the available knowledge and all the evidence and help decision makers explore alternatives. They are a decision support tool, not a decision making tool. It helps us process knowledge, but is no substitute for wisdom, foresight or difficult negotiations. In fact, BBNs are most useful in situations where there are conflicting beliefs that make negotiation difficult. By formalising and representing these conflicting views, the BBN can help resolve disagreements by making the reasoning behind choices more transparent. The initial BBN we tried was essentially an epidemiological model describing the probability of a new human infection given some understanding of Campylobacter transmission networks. And as you recall, it looked like this. This was built with John Holt's defined illustrative probabilities in the expectation that sufficient data could be collected and the model reparametrized based on these data. We now know that there won't be enough data to parameterize such a detailed transmission network. However, it is possible to build a detailed model of interventions based on our understanding of society, economics, institutions and cultures, and link it to the utility functions representing the impact on disease, for instance measured in dailies, the disability adjusted life years. So here are a suite of likely interventions, and with them some inclusion of financial instruments that might attract a policymaker's interest. By focusing on key obstacles to successful public health interventions, such as money, education, gender equality, we're more likely to influence policymakers and perhaps even encourage the flow of finance. We can build an exploratory BBN with available local knowledge, literature review and project data, and try to better understand the sources of uncertainty that change our beliefs about successful interventions. In particular, we can evaluate how better knowledge of transmission networks affect these beliefs. Thus, by identifying key influencing factors, we can then prioritise further research. What stands in our way? Well, the complexity and variability of the risk of infection for each child. The risk can depend on many economic, environmental, cultural and social factors that are hard to observe and model. The lack of reliable and standardised methods and indicators for measuring the impact of CAMP infections and related infections. So we lack prevalence and incidence data, and hence any daily baseline. Further, data on the quality, efficacy and coverage of existing or possible interventions is sparse. It's difficult to attribute changes in CAMP or other infections to specific interventions, especially when there are multiple or overlapping interventions or confounding factors involved. The key limitation of a BBN is also its advantage, namely the ability to represent subjective beliefs. Given the uncertainties mentioned previously and the lack of knowledge and suitable scientific data on interventions, any BBN that we build will start with the subjective opinion of local experts. Further, building a model that is genuinely useful and informative about potential solutions to local problems requires us to engage deeply with local experts and requires their time too. This is especially true if the model pays careful attention to implementation and potential chances of adoption of any proposed measures. Unpicking different social and cultural obstacles to implementation needs time to deliberate and explore and possibly argue to agree on uncertainties. We already mentioned some of the interventions that we could consider alongside finance measures that would make these interventions feasible and attractive for local authorities to explore. So community-based education, awareness campaigns on causes and symptoms and prevention. We can explore novel forms of communication, infographics or cartoons, which could be in local languages and be culturally appropriate. One of the key interventions is ensuring safe water at the household level. Subsidies for domestic filtration or chlorine tablets could also be explored. A harder target is reducing contact with animals. But education, subsidies for coops, feed of chickens, and better practices at markets and slaughterhouses can be encouraged. We can also consider measures that empower the community and local authorities to monitor water safety at public taps. Finally, improving food security and reducing malnutrition among children will make children more resilient and thus lessen the burden of disease. We envision working closely together in a small expert group. The first step would be to consider the objectives and utility functions that are of relevance to local people. Then we can brainstorm interventions that might achieve those. Then we can build a model that can inform the probabilities, the likelihood of achieving objectives with specific interventions. Once we have this conceptual model, we will need to specify conditional and unconditional probabilities. So let's work through an example in the next few slides. We can simplify the transmission network to account for the four main routes: so food, contact with animals, water, and other indirect transmission pathways through surfaces in the kitchens, toilets, the compound, the farmland, the markets, and including person-to-person contacts. So in this actual BBN, we've simplified those into one variable, safe and clean environment. So this four-node model reflects the general understanding that children's health depends on growing up in a safe and clean environment and having good food and health care. In the vocabulary of the BBN, we would say that the children's health node is the child of three parent nodes. Here, we're finally starting to see how the model actually works. So first we need to specify the states of the variables and their prior probabilities before any further action is taken or observations are made. So the clean and safe environment here has two states. It's true or it's false. Same for the others. The binary is not ideal, but it illustrates approximations that are common in such BBNs. In this network, the chance that a child is living in a safe and clean environment is 60%. Or 60% of children are believed to be living in a safe and clean environment relative to some threshold of what safe and clean actually means. The most complicated part of this network is the probability table for the child mortality under 5 is high variable. Here we need to specify the probability that the variable is in a true state given all the combination of the other three parent variables it depends on. So for example, the lowest probability, 10%, 0.1, that child mortality is high occurs when all children are living in a clean and safe environment, have adequate nutrition and access to health care. Here, we show how information can travel across the network. We can see two versions of the network. Top left, where no observations are entered. These are our prior assumptions. And on the right, one where we observe that child mortality is high. We can see that the distributions are updated, but some are updated more than others. So the strength of the connection between the variables is determined by conditional probabilities. So when we built the network, we specified that mortality was more dependent on the clean and safe environment than other variables. And this is why when we observe mortality, our beliefs about environment are updated more strongly than our beliefs about other variables. Here, we believed that 60% of the kids had access to a clean and safe environment before observing mortality. But after observing that mortality is high, we conclude that about half of that, only 32% of the kids, enjoy a clean and safe environment. Conversely, if we observe that the mortality is low, then we must have underestimated the number of kids who live in a clean and safe environment. Instead of 60%, it's now estimated to be 75%. The information can also travel from parent to child variables. So, for example, here we observe that all kids have access to good nutrition and a clean, safe environment. This then updates our beliefs about child mortality. Whereas before we thought that there was a 66% chance that mortality is low, we are now more confident, 88%, that it is so. Building a BBN for this project needs both the data that the project collects and your expert knowledge and familiarity with local context. Especially useful will be the data on socio-economic conditions, education, hygiene practices, beliefs about disease, and the obstacles that people face in trying to make sure that their kids are safe. We can include the data on which transmission routes are more likely that will come out of the Campylobacter genetics data. And we can then explore the value of this information by showing the impact on the BBN of the transmission data from GetCampy. How can you contribute? You can help us construct a network describing the possible interventions and their efficacy. You can help us condition the network on your beliefs and experience. So we cannot and absolutely should not do this without you. To learn more about decision-making tools, if this subject interests you, if you're enjoying thinking about this, then do have a look at this publication from the AU4DM network. And finally, as climate change has many important health implications in the context of diarrhoea and health generally, you can read more about this area in this free publication. Thank you very much for your time. I want to thank Polina for putting this together for me. I hope this has been of interest, and I hope it's explained to you a little bit of what we're doing and how you can help us to do it. Thank you.